and then we will go that when the baby delivered, what to do. So inshallah, we will discuss more about that. Okay. So I have no financial conflict of interest to disclose. Why I am showing this slide, because I have to tell something, some different kind of surfactant, but I have nothing to do with that, and some mode of ventilation also. So this is the simple objectives, the definition, pathophysiology, management, to agree for the best management and noticing improve outcome. Okay, all this we will discuss it, and by the end of the thing, lecture or the talk, it is expected to be change of practice. Thus, I really adhere to some point. I know you are all doing a very good job regarding that, but I want you to adhere on some practices which we can make a lot of difference in the outcome of those babies. So the introduction is the respiratory distress syndrome is the most common problem in the newborn, especially in the premature babies, and typically affect below 35 week of gestation. And why it is like that? Because the lung maturation, I will show you the diagram on that. Then we should know what is the criteria for diagnosis. But before go into that, we have a different kind of definition. This is a very busy slide, but look at that. WHO has some definition. Then NICHD, which is the National Institute of Child and Health Diseases in USA, there the insurance system have ICD-10. Now for the code diagnosis, then archive have some. Swiss society has their own definition, the Chinese has their own definition. So if you go through it, the all of those definitions is almost the same, a little bit different. So this is the main thing you have to understand, that first of all, what is the meaning of tachypnea, bradypnea, and apnea? And you all know better than me the respiratory rate of 60 or more breaths per minute is the tachypnea, less than 30 breaths per minute in the newborn is bradypnea, and cessation of respiratory effort, it means no breaths for at least 20 seconds. Now with that, if you have a clinical symptom, nasal flaring, noisy breathing, grunting, stridor or wheeze, retractions, central cyanosis, all this can add up, and we call it respiratory distress syndrome. The incidence, if you take it overall, because it includes the full-term babies also, so it's only 1.16. But if you see in the premature babies, especially in extremely low birth babies, almost 90% of that babies has this thing, and up to 1,000 gram, up to 80%, and so on and so forth. And this is the data from Maureen Hackett last year. The reason that is we all know that there is a deficiency of the surfactant. Now, this is the slide which I want you to take a look and just for 1 or 2 minutes concentrate on that. There are two more stages, total of 5 stages: embryonic, pseudoglandular, so up to 16 weeks. So we are not concerned because we think of the abortion. We are more concerned about the secular stage and alveolar stage, where we have most of our babies in these stage. Now, there are many other factors which can affect the development of lung. For example, steroids help in developing lungs, antenatal exposure, chorioamnionitis can damage the lung, intrauterine growth restriction can help in developing the lungs, and the stage of RDS in those babies are milder or moderate as compared to the normal weight babies. Then postnatal exposure is, of course, ventilator can induce injuries, oxidative stress, steroids can help, but they have other side effects. We will go through it. Most important thing is to remember there is and those who are preparing for exam, there's a lot of, there's almost every time they ask what is the difference between new BPD and the definition of old BPD. So the developmental arrest or the delay is called the new BPD, and the old BPD is the structural injury because of the other factors which is mentioned, and that is a normal development. So we have to understand this part. Okay. Okay. So I showed you this table before in my talk of the how to approach respiratory distress. But anyway, again, to just for reminding us ourselves, this is the embryonic, pseudoglandular, cranicular, terminal, and or secular and alveolar stage. And different stages have different diseases. If you have arrest at example secular stage or terminal stage, you can get RDS and BPD. Now, what is the pathophysiology? One simple vicious circle, everybody knows. The most important is the diminished surfactant. And why? What are the factors? Risk factor, I will show you more. But for example, acidosis, familial predisposition, I will talk about genetics in one of the slide, prematurity, C-section, interpartum asphyxia, all can lead to diminished surfactant. It leads to atelectasis, it leads to hypoventilation, it increases the PCO2, decrease the PO2, decrease the pH, it can cause the hypotension shock, pulmonary vasoconstriction, alveolar hypoperfusion, and impaired cellular metabolism, again, which inactivate the surfactant. So it's a very vicious circle, which we have to understand this. Remember, there is a pulmonary vasoconstriction can happen in those babies. And why I'm saying that, I will come back to that. This is just a very old slide from the book of our pathology, which we all read, that initially we call this hyaline membrane disease. And why we are calling hyaline membrane disease, because if you do the staining, hematolin or eosin stain, you can have this pink color membrane, which is the hyaline membrane. Okay, it is not present in a normal lung. So that's why we call it hyaline membrane disease. As I told you that we talk about the genetics because there is a genetics predisposition. So for example, monozygotic twins have a higher incidence for as compared to dizygotic twins. The genetic causes of surfactant protein deficiency can also present with the varying degrees. The most important one is, but it's rare, but it is important, is autosomal recessive mutation of SPB genes. SPB protein, you know, is a part of the surfactant protein, which help in spreading the surfactant throughout the lung. The SPC gene mutation can also present in 0.1% of the population. There is another gene called ABCA3 as a subfamily A member 3 gene, which can also affect that. Although about 4% of the population reportedly carries this deletion, the exact incidence of the fatal RDS in this population is unknown. So there is a strong genetic predisposition of this disease. Now, you all know this is a bookish picture, very old slide from Danny at European Respiratory Journal in 1999. And this is, you all know that this is the prematurity, male gender, familial predisposition, asphyxia, Caucasian race, infant of diabetic mother, chorioamnionitis, and non-immune hydroxyperotalis all can cause in the respiratory distress. And these are some which can decrease the risk. So let's start with some scenario. So 30-year young preemie admitted in the labor room with a 30-week gestation, having fever and leaking membranes. OB diagnosis PPROM, which is prolonged premature rupture of membrane, decided to go for ELSCS, emergency LSCS. So I discussed this in my previous talk about antenatal steroid and magnesium sulfate or antenatal steroid in the late preterm of 35 to 37 weeks. So let's see. So these are the recommendations for antenatally before the baby delivered. These are combined recommendation, and this is the consensus from the AAP and the European guidelines. that if the mother had a high risk preterm, let's say 20, less than 28 to 30-week gestation, it should be transferred to the perinatal centers or the centers where have a tertiary care, because not all the centers have the facilities and the resources which are required for those babies. Of course, if the mother come and just deliver, you have to stabilize the baby and then transfer. The clinicians should offer a single course of corticosteroid to all women. As I discussed before in my previous talk, your risk of preterm delivery when pregnancies considered potentially viable until 34 weeks. By the way, this is a very strong evidence of that. We are giving steroid up to 38 weeks of gestation. A single repeat course of steroid may be given if it is happen at least 1 to 2 weeks earlier. Magnesium sulfate, I showed you the pre-MAC trial uh, in the talk of affecting the prematurity, that it helped as a neuroprotective effect. So all those mothers who have imminent labor before 32 weeks should have magnesium sulfate. So you should communicate with your OBG that these are the recommendation, please follow those, okay? And there are a very high recommendations on that. A1 means the highest level, A2 and A2. So this is, you should communicate with them. So I will not stay much on the on this slide that before we had discussed already that antenatal steroids are very important, and it helps not only in the RDS and development in the lung, but also in the neonatal death, intraventricular hemorrhage, and NEC. The NEC, of course, it crossing the line of confidence interval, but the trend is toward preventing the NEC and favors the treatment. So we should give the antenatal steroids to all those mothers. And this is the antenatal betamethasone used in the late pregnancy. These are the results. This, if you cannot see, but it's just published in the New England Journal in 2016. And this is a very good article if you want to read about antenatal steroids. And as you can see, the most of them is not crossing the line of confidence interval, and statistically it is significant. So antenatal steroid, especially the antenatal betamethasone, is very much helpful in improving the outcomes of our premature babies. So let's say the baby delivered, estimated weight 1 kilogram, 1.2 kilogram, looks pink, shallow breathing, heart rate 110, mild chest retraction. Now, the question is arise, and who attend the NRP update, that they should know that how to measure the heart rate. And I also discuss about the delayed cord clamping or the milking. So these are the two main questions as soon as the baby delivered. Now, the heart rate, we have a stethoscope. Yes, we pulse ox if present. This is two things I recommend. If you have resources, kindly please buy the pulse ox if you don't have. And the other thing I will tell you later. The ECG leads, I think most of you have it. Try to apply it. We are applying the ECG leads or EKG leads in the delivery room to have the heart rate. We have other technologies also, but no need to be going through very advanced to spend money on those. But at least you should have these things, because the stethoscope auscultation may not be that accurate. The pulse oximeter, it will take at least 2 minutes to get the correct heart rate. EKG is the most accurate. In Britain, they start wireless cap sensor also, but no need to go and to buy that. The other thing is that we discussed initially also about the cord milking and delayed cord clamping. So any baby less than 30 weeks or less than 28 weeks, please do not do the cord milking. It can change the pressures in the baby. So the cerebral autoregulation. What is cerebral autoregulation? Those of you who are doing swimming, they know कि आपने, we call it diving seal reflex. तो आपने जब dive की And when you go inside the water, the pressure of that, then all of a sudden all the viscera try to oxygenate or to give perfusion to the brain. It is called the autocerebral regulation, that the changes in your blood pressure not changing the pressures in your brain. So this is not present in our premature babies. So what happened that if you do the cord milking, they find it out that there is a chances of having severe grade IVF. But the delayed cord clamping is approved and is recommended, and as you can see, that it help in decreasing the severe IVH. Another thing, when the baby delivered, we rush for suctioning the babies. I told you before also, this is another very comprehensive articles, and many big names, Wally Carlo and Embla Venen was involved in this article. It's published in 2013 in Lancet, and they find it out that just the wiping of the mouth and nose at the birth is same as suctioning the baby. So because if you do the suctioning, it can delay. I think in one of my talk, I showed you the statistics of that also, that it delayed the oxygenation. So unnecessary of any procedure, you should be avoided at. If the baby don't need just some secretion, you can wipe it out, and this is enough. So baby delivered, we did the delayed cord clamping, we did the initial steps. Okay, now come that how to do the other things. So up till now, these are the recommendations. I will give you in each step the recommendations from AAP and the European guideline, which is published last year, 2019, which is the latest one. Delayed clamping the umbilical cord for at least 60 to promote the placenta-fetal transfusion, and it's a very high evidence, as you can see. In spontaneous breathing babies, stabilize with the CPAP. I come to that. Do not use sustained inflation. So what is sustained inflation? That you give some pressure and give continuous without relieving it to the baby for at least 10 to 15 seconds. But it is no long-term benefit because the chances of having pneumothorax in those babies are higher with that. So it is not recommended. Gentle positive pressure lung inflation we should give. We will come in a few seconds about that. Oxygen for resuscitation, I will come to that, but we have to use a blender. Now, this is the problem. हमारे पास वहाँ blender नहीं है. This is the another thing which we should think of buying. मेरे ख्याल में इंडस में है, आखान में, लेकिन और जगह मुझे नहीं पता, लेकिन ज़्यादातर जगह blenders नहीं हैं. Use an initial FiO2 of 30% if the baby is 28 weeks, and then 21% if it is a baby is more than that, and then titrate accordingly. For infant less than 32-week gestation, SpO2 of 80% or more should be achieved within 5 minutes. देखें, this is very important to understand. एक तो हम लोगों को जल्दी बहुत होती है. This is not correct. The baby is still in the transition. We don't want 100% oxygen at 5 minutes of life. So आप सबने माशाल्लाह NRP किया हुआ है, आपने ये देखी भी होगी. These are the saturations. These are the minutes of life. So let's say 5 minute में 80 to 85% आप अचीव कर रहे हैं, अगर saturation is more than enough. Don't try to give a lot of oxygen or bag and mask, which can injure their lung. So 6-7 minute में देखें, 6 minute में it's reach up to 80-85, and it take almost 10 minutes to reach the 90 and above. So that's the way we should react on the babies. किसी बात की जल्दी नहीं है. The babies are doing very well and they are strong enough to keep with that. So The next one, intubation should be reserved for the babies not responding. अगर आप कर रहे हैं और baby respond नहीं कर रहा, तो that is okay. Then you don't have, but we will come back to that. Baby who require intubation should receive surfactant, but I will give you other recommendation about that. Now, this is another bookish thing. I hate to put it in the talks because ये सब आपको पता ही होगा. Sign and symptoms क्या हैं, complications क्या हैं, you can find it out anywhere in any book. ठीक है, तो we will not spend too much time on that. PVL, IVH, NEC, ROP, PDA, everything. These type of these scores can help you in deciding which baby needs what kind of a support. So there are two scores I showed, I think before also. This is called Down's score or Downey's score. Downey is the name of the person who developed it. This is 0, 1, and 2 minutes. The higher the score, the severe the stage of the RDS. Similar, Silverman Anderson disparity score, that higher the score, you calculate that what kind of a movement the baby has is more kind of objective. And then if they have grunting or anything, so you calculate everything and put it as a total. The higher the number, the severity is higher on that. This is the same score, but in just in a tabulated form. That's no brainer. Now come to the differential diagnosis. The differential diagnosis is easy, but there are some overlapping of the system of the silent syndrome. For example, RDS, transit tachypnea, PPHN, and meconium aspiration. So the major difference, that meconium and transit tachypnea is the full term, mostly the full term baby affected, and the respiratory distress and PPHN is the preterm difference. Then the etiology is different, the risk factors are different, onset of the symptoms are different. I just give you the table so you should know just for your information. Then clinical features are different in different level, imaging are different. I will show you in a minute. In RDS, the treatment, of course, is totally different, and the complications are different in these things. So you can easily differentiate which kind of a disease you have. So the baby delivered, आप उसको CPAP पे लिया है, वहाँ से delivery room से, you are now in your NICU. So the investigation, you have to do the CBC, you have to do the blood culture, you should start the baby on antibiotic, and of course you have to do the blood gas. All those numbers are the arterial. Please do not think of the CBDs, because CBDs has a totally different criteria. So these are the arterial blood gas. If you have a preductal PaO2 is 50 to 70 mmHg in your pulse ox, and the 90 to 94%, the PaO2 up to 80 mmHg is acceptable in the term infant. The PaO2 of less than 50 is hypoxemia. Low normal oxygenation is 50 to 60, and hyperoxemia is more than 80 in preterm and more than 90 in term. The PCO2 is 35 to 45 is normal. The upper limit is 45 to 55, but in the premature baby, we allow up to the 60 arterial. We never allow the hypocarbia because it can increase the risk of the PVL. So again, these are the scoring system. If you have the PO2, pH, and PCO2, let's say if it is more than 67.3, less than 50 of PCO2, then the score is 0. The higher the score, the higher the severity of your RDS. Now, these are the different lungs. It looks like the same to you, but I don't know how you can see it, because, of course, when it is you are seeing direct on the screen, it looks different. But typical reticulogranular pattern is the class 1, stage 1 RDS. If you starting having the bronchograms, as you can see here and here, then it's a stage 2, and fully developed like a PIE. No, it's not a PIE, but fully developed these bronchograms, a lot of bronchograms with all this haziness, is the stage 3. So it depends what kind of X-ray you are getting when you are having those babies. So how to differentiate? So in RDS, you have air bronchograms, reticulogranular pattern, loss of lung volume, atelectasis maybe, pneumothorax and pneumomediastinum. So if you, it's easy for you, you can differentiate from other conditions like pneumonia, mass, or retained fluid, fetal lung liquid syndrome. You can differentiate easily with that pattern. Vikram asked me to talk a little bit about lung ultrasound. To be honest with you, I am now learning. I'm doing the lung ultrasound as soon as the baby arrives to our NICU. But to be honest with you, I am also in the learning. So I will give you, this is the very handy tool just to check what condition the baby has. And it is, of course, there is no radiation. Excuse me. So this is the ribs. This is the normal when you put it in a normal baby. This is called pleural lines and this is called A lines. Okay. If you have a baby with the RDS, you can have the ribs, but see the pleural lines are disturbed and the A lines are gone. And on top of that, you having this mass, which is a lung consolidation, and there is a air bronchogram. Another picture, you have the ribs, there is pleural lines, but there is a disturbance of the pleural lines here. And then again, you have the lung consolidation, this black spots here. So if you see the lung ultrasound in different conditions, so RDS, the disturbance in pleural lines, absence of A lines. Right now, I'm in that learning stage that I'm just focusing on these two to learn how to identify it. But there are different things also, lung consolidation, which I already showed you. This is the third thing. But double lung point, pleural effusion, pulmonary edema is still, I am learning on that. But I'm telling you, as soon as you receive the baby and you know how to do it, is a very handy tool to do the lung ultrasound. And now it is it's a very much in many of the our NICUs. Now the baby is with you, so you have to do procedures. So intravenous lines, umbilical arterial lines, umbilical artery cut down, we don't do it unless and until the if you don't find anything peripheral, and we call pediatric surgeon for that. Peripheral arterial cannulation, sometimes we do, and umbilical venous catheterization. But each procedure depends on the condition of the baby. If the babies are very sick, then of course you have to continue that. Otherwise, there is no need for doing all those procedures. So, how to oxygenate the baby in the delivery room first? So, I know there is the many of the centers in the Pakistan, they don't have the neopuff. NRP is not recommended the bag and a mask, okay? But if you have the bag and mask, and if you don't have this one, लेकिन आप ये देखें कि इसके ऊपर भी एक मैनोमीटर लगा हुआ है, तो ये भी अगर आपके पास है तो चलेगा. इसमें आपको पता चल जाएगा कि how much pressure you are giving. The whole idea not to over ventilate the lung or not to give a lot of pressures to the babies. Preventive functional residual volume, limit chest expansion, we will come to that. So the CPAP in delivery room is the main treatment for those babies. All you know the how it help, it increase the pharyngeal cross sectional area, decrease the airway obstruction, reduce the obstructive apnea, increase the FRC, and by doing all this, it can reduce the BPD and reduce the need for mechanical ventilation. Now, why we are saying that? So when I'm talking to Dr. Peter Davis, he's a very good friend of mine. He's in Australia. And he sent me this article, and he said that because 80% of those preterm babies, of very small babies, is breathing at the time of birth, and 69% are tired to crying. So it means they are having some effort of breathing with them, okay? If you go by less than 26 weeker, it's still 67% breath and 56% cried. More than 26 weeks, 86% breathing and 74% crying. So this help you to understand that the CPAP is the first choice for all those babies. Again, Vikram is arranging for ventilation and non-invasive, so we can discuss in our non-invasive ventilation talk. Uh, there is a lot of trials, more than 2,000 babies, and all go in favor of, this is the Cochrane review in 2016, all go in favor of CPAP, that these babies can do better in the CPAP. This is just one of the meta-analysis. I want to show the death or the BPD is less from the same Cochrane review, as you can see here, favor the CPAP. But my response to this, or our practice to this current evidence, is for preterm babies breathing well at birth, and CPAP is appropriate first-line treatment. But to give them, if the baby is less than 27 weeks or 28 weeks, I have a very low threshold to give the surfactant as early as possible. The coin trial suggests if the pressure is going more than 6 centimeter or 40%, but I have low threshold. I will show you in my last slide what we are doing. Is this right? Yes, it is right to give surfactant as early as possible. CPAP is not the magic bullet. If you remember, I showed you that for less than 27 week, 40% to 48% can have the failure on the CPAP. So that's why the search continues, and there's a lot of still doing on that if CPAP or NIPPV we should start, but it is still. Then CPAP and surfactant without the ETT, yes, it is possible. We already talk about surfactant, how to give surfactant in LISA technique. Just a couple of weeks ago, I gave that one, but I will go through it. I will show you one slide about that. Now come to the surfactant. There are many kind of a surfactant. There are natural and synthetic surfactant, early rescue in the ventilated baby. So as early as one. I will show you what is the meaning of early rescue and prophylaxis. Insure or LISA will know about that. Second or third dose nowadays are rarely needed. So this is the surfactant thing. This is the one of the major or one of the best studied drug in the neonatology. Look at that, 150 RCTs, 25 Cochrane reviews. But the problem is that, or the caveat is that many of those RCTs done before the routine use of antenatal steroid and the CPAP. So that's why they are saying that the prophylaxis is better. But when they did the trials after the CPAP, or the antenatal steroid, then the early rescuer is better. Anyway, so the composition of surfactant, just for your information, 10% protein, 5% neutral fat, 4% cholesterol, phosphatidylcholine disaturate is the highest, 40% phosphatidylcholine monosaturate is 25%, glycerol is 8%, and others things are 8%, just to give you an idea. What is the pathophysiology, how the surfactant help in RDS? Again, this is a vicious circle. There is a, first of all, there is a deficiencies as we already discussed in those premature babies. On top of that, there are some factors which we already know, which is we call the risk factor. The lower the gestational rate, the higher that the surfactant pool is less. Prenatal stress, inflammation, okay? Then the inactivation and top of that deficiency, it can cause the severity of RDS, and it causes lung structure problem and tissue function problem. And then again, it can inactivate the surfactant. So what happened, this is Alan Job work. He's one of the pioneers in doing a lot of work on the surfactant. So what happened in the alveoli, which is without surfactant and with surfactant? As you can see, the simpler physics, if you remember, from the higher concentration, from the lower concentration, it go to the higher concentration. So the P1 is much, much greater than P2. The small alveoli are not stable and collapse into larger ones. The P1 is greater than P2. So what happened? The pressure from here to transfer to the here. So the one alveoli is getting bigger and bigger, the other alveoli become collapse and collapse. Here, because of the surfactant, the smaller alveoli also maintaining its surface tension, and the bigger alveoli is the same. It's not going bigger and bigger. So this is the main function of the surfactant in our body. So use surfactant early. You can give surfactant without intubation. We all know that. There is one surfactant called the leucinectant, or this is the synthetic, but it is under research. I will show you which type of the surfactant. So come back to first to prophylaxis versus rescue. So the pre-CPAP literature, as I am telling you, that is still prophylaxis is better than rescue. The CPAP era is saying that decreased death or BPD is stabilized on CPAP, then give the surfactant is much better. So this is the early surfactant with rapid extubation ensure technique, and it found that it helped in all kind of parameters, BPD, intraventricular hemorrhage, and all others. So how you can give surfactant? Early rescue surfactant you have to give. Either you give by ensure technique, that you intubate the baby and extubate it, the LISA technique, the laryngeal mask administration, or nebulization. The nebulization is still under a lot of research, but it is going to be revolutionary because it is very easy to give surfactant if it is approved by the FDA and other agencies. Laryngeal mask administration is easy, but it cannot be done in less than 1,000 gram because you don't have the size available. But let's say if you don't have, if you have a 32, 31 weeker, you don't know how to intubate, then if you have laryngeal mass, you can use it and give surfactant. The insure technique you all know, but major thing is that, and what we are doing is this, that we give the angiocath, and now the catheters are available for doing this procedure. We give the surfactant through when the baby is on CPAP or NIPPV, and we continue to give the surfactant. There is no sedation needed for that. There is a difference. There's a death and BPD decrease by 12 to 10% in the hair, but here you can see it's 25%. This crosses the line of confidence interval of 1. Here it is not crossing the line, so it's statistically significant. What are the types of surfactant? We have Beractant, which is the called the name of Serventa, and then we have Poractant, which is the derived from the pig or pork. This is called Curosurf. Then we have Calfactant, which is from the calf, also from the bovine. It's called Infasurf. Leucinectant, I told you about, is a synthetic made in the lab. It's called surfactant. There's a lot of research going on about the efficacy of that. And then aerosolized surfactant, again, we have a lot of research is going on. The mainly two surfactant which they are talking about are the Beractant and the Poractant alpha. And there are some recent in the Cochrane library that the Poractant is better than the modified bovine surfactant. And the reason for that is the dosing. The Poractant is 200 versus 100 milligram per kg. So the dose is high. So most of the result because of the dosing. And the good thing about the Curosurf or the Poractant is that it is low volume and high dose as compared to high volume and low dose in the Serventa. So they said it's more rapid improvement and decreased mortality. मेरे ख्याल में पाकिस्तान में भी अवेलेबल है, यूज़ हो रहा है यहाँ पे भी, और सऊदी अरब में भी उसके उसमें जो शरिया कोर्ट है उन्होंने फतवा भी दे रखा है कि इट इज़ जायज़ टू यूज़ दिस. ओके, So the recommendations for this part of the talk is baby with RDS should be receive animal-derived surfactant, okay, because synthetic surfactant is going to be the cheap, but the efficacy we don't know. The early rescue should be standard. So as soon as you think, give the surfactant, and such as when intubation is needed for stabilization. Baby with RDS, give rescue surfactant early in the course of the disease. So what we are doing, if the baby require more than 30 and more than PEEP of 6, we give the surfactant. According to those studies, the poractant is more better than the other surfactant. And Lisa is a preferred mode of surfactant administration for spontaneous breathing babies on CPAP. So these are the current recommendations. And all these we can do in Pakistan very easily just to develop the techniques only. ऑक्सीजनेशन तो अब बचा है आपने सी पैप भी दे दिया और ये है उसको सरफेक्टेंट भी दे दिया तो ऑक्सीजनेशन कहाँ पे रखनी है before we are keeping the oxygen at 85 to 89%, लेकिन then they did a lot of trials and they found it out. It is increase in the neck, increase in the mortality. So now the current recommendation is 90 to 94%. The alarm limit in the pulse oximeter, you should put 89 to 95%. So we are trying to keep, do our best to keep the saturation between 90 and 94%. अब जरा थोड़ा सा मुश्किल मरहला कि बच्चा किसी भी तौर पे सही नहीं हो रहा तो you have to ventilate the baby. Which type of ventilation or which type mode you should use? देखें, whatever the ventilator you should master one mode और उसको आप बार बार अप्लाई करें, you will get better outcome. It's like जोडू कराटे. अगर आप कंग फू है, अगर आपने ब्रूस ली की पिक्चरें देखी हो तो उसमें उसने यही डिस्क्राइब किया है, जो उसकी डॉक्यूमेंट्रीज हैं, कि कोई एक मूव आप बार बार करते हैं ना तो उसमें आप मास्टर हो जाएंगे. 10,000 मोड्स हैं आजकल मार्केट में और वो 10,000 मोड्स में अगर आप उसको एक्सपर्ट होना चाहेंगे, इट्स रियली वेरी डिफिकल्ट फॉर ऑल ऑफ यू. दैट्स वी डिड इन आवर यूनिट. वी आर, because we are a tertiary center, we are research center, Mayo and John Hopkins. So we are using actually 3 modes in different babies, but mostly if the baby getting mechanical ventilation, we are using volume targeted versus mode as compared to the pressure limited. And why it is? Because if Cochrane collaboration में जाएं आप, you lot of evidence, death or BPD favor volume target. Death in hospital, no difference. Death, BPD 36 weeks favor volume targeted. IPPV days less in volume targeted, as you can see. And any pneumothorax is less in favor volume targeted. Severe IVH or PVL favor volume targeted. So just concentrate on volume targeted. High frequency is another good mode. Vikram, I think, arrange a talk on a high frequency later on, so we will talk about that. But right now I'm giving you a basic of this volume targeted. So if you see the conclusion of these studies, the VTV, volume target ventilation, is better. Less death or BPD and number need to treat is only 8. Less pneumothorax, number need to treat is 17. Short duration of ventilation and less severe cranial ultrasound abnormalities. Survey of the practice right now. This is published in 2018, so just 1.5 or 2 years ago. VTV used in 60% of Australian unit versus 70% in US versus 50% in Nordic. Nordic means ये जो Norway, Iceland और Denmark वगैरह हैं, Nordic races जिसे कहते हैं. Why? Because I showed you reduced BPD by 52%. Those who are not using it, why not? Happy with the current strategies, they said in this survey. This 52% of that, as I showed you, in the Nordic countries. The target volumes, 5 for the RDS and 6, I will come to that in a minute. So what are the physiological volume in the term unit? There is no hard and fast rule. एक study published in 2010 is 11 to 26 ml, not reported to the body weight. So अगर आप उसको divide करें तो इस 3 किलोग्राम बेबी है, so 4 to 8.5 ml per kg. एक स्टडी में 19 टू 25 ml, 6 to 8.5 ml per kg बनता है. इसी तरह प्री टर्म में भी कोई अभी तक एविडेंस नहीं है कि which one is to start with. So Dr. Martin Kessler did this table and make easy for us. He published this first in 2015 and then again in 2019. It is published by him and his colleagues. And these are the suggested volumes. Okay, I will send this talk to Vikram and you can have it. And we are following these guidelines. The preterm infant अगर है और RDS उसको है और more than 2000 gram है, we use 4 ml. अगर 700 to 1500 है, we use 4 to 5 ml. अगर less than 700, obviously he needs a little bit more. So smaller the infant, larger tidal volume needed. Okay. अगर meconium aspiration term infant है तो 5 to 7. अगर term infant with congenital left rheumatic hernia है to 4 ml. Term infant with pneumonia to 4 ml. So these are the some kind of a guidelines which we have, and these are the pressure limit or PIP here. So this is a very handy guidelines. We can use it. So these are the ventilator settings. So first of all, you should select the access control on your ventilator. Y-axis control we will talk about in other talks because of the this talk getting too long. So add volume guarantee, then set the desire according to the condition of the patient, according to the age of patient. As I showed you in the previous slide, is 4 ml per kg. The target range of PCO2 is 50 to 55. Use tidal volume more than 6 ml is not recommended in most of the settings. So these are our setting: 4 ml per kg, 25 centimeter of water, P5, inspired 10.3, backup respiratory rate of 60 breaths per minute. It is very easy and it is a conventional ventilation protocol. You can adopt it. How to wean? It is the auto weaning mode. तो होता क्या है कि when you set the tidal volume, okay, the pressure adjusts itself to give the same tidal volume. So let's see in this graph. So this is the tidal volume, okay. You put it, let's say 4 ml per kg. आपने अभी surfactant नहीं दिया, he's requiring a lot of pressure. Surfactant दे दिया, the compliance improve, the pressure come down, and the tidal volume remain the same as you put it. So this is called auto weaning. Okay, if the target tidal volume is set too low, the PIP will reduce and the patient may be supported with CPAP only, which may lead to failure. So you have to choose not less than 4 and not less than 6 ml per kg in these premature babies, the tidal volume. So if weaning has decreased PIP to low level, it means your baby is ready to extubate. अच्छा, अब tidal volume should not be set, मैंने अभी जैसे कहा कि less than 4 ml. The mean airway pressure 8 to 10 centimeter using a tidal volume 3 to 4 ml kg with acceptable gas. The infant should be ready for his extubation. So 4 ml per kg पे आपने सेट किया हुआ है. Mean airway pressure आपको दिखा रहा है आपका ventilator 8 to 10 centimeter. Or the blood gas are fine. It means it's the time to extubate your baby. There are some problems with this mode that you should avoid the overventilation. The overventilation is that the infant does not breathe above the ventilator, so it means no triggering, and the PCO2 is too low. So that's give the PCO2 is very low, so we have to avoid it. And how can we do that? Change it to the SIMV mode, which can control your rate and decrease the rate, and so we can control the hypocarbia. Under ventilation is very easy. If you think that the baby is not improving and the baby is not, so either increase the PIP or increase the tidal volume from 4 to 5 ml per kg per 5 ml per kg. So short inspiratory time can also help, and inadequate flow, especially at high rates. So these are the essential of these volume guarantee ventilation. Actually, I have full talk on that. Inshallah, कभी हुआ तो इसको discuss करेंगे. लेकिन just a snapshot I am giving to you. सो ईटी ट्यूब इज लेस देन 50% लीक, क्योंकि अगर लीक होगा तो वो प्रेशर जो है वो उतना वॉल्यूम नहीं दे पाएगा जितना आपने सेट किया है. The inspiratory pressures reach plateau before expiration. The tidal volume is high enough to support the infant's breathing effort. So अगर आपने 3 पे रखा तो वो उतना नहीं होगा. So you have to go 4 and above. And the circuit gas flow and PEEP should be around 5 and not less than 5. तो ये हो गई ventilation. अब other strategies which help the baby in RDS is caffeine. We all know permissive hypercarbia. We all know postnatal steroid. I will give you one or two slide about that, and high level of CPAP maybe. So caffeine for apnea of prematurity, I think 2 weeks ago you got that talk and you know all this about, and of course caffeine is very important for all those babies. Start day one with the IV caffeine and then shift to the PO caffeine. Postnatal steroid, we are using, but after the 1 to 2 weeks of age because of neurodevelopmental outcome. If you use before the 1 week, then the bad neurodevelopmental outcome as compared to after 2 weeks of age. Agar you are suspecting that this baby is going to develop the BPD. These are the DART protocol. 1 to 3 days, you give 0.15 milligram, then 4 to 6, and then 9 to 10 days, total 0.89 milligram per kg, and so on and so forth. Avoid the hyperoxia as much as possible because it can, of course, give the lot of oxidative stats. So European consensus guideline, delivery room is 21 to 30% again and again, and postnatal about 90 to 94% saturation is enough. Other things which help the baby in extubation, of course, caffeine, and after extubation, either you can put on CPAP or NIPP. NIPPV means non-invasive positive pressure ventilation. It means कि आपने उसको कैन्युला लगाया और उसको अटैच कर दिया वेंटिलेटर से and give pressure, PEEP, PIP, PEEP, and oxygenation with the. So it is a kind of a ventilation but non-invasive. And dexamethasone DART protocol we already discussed. So NCPAP immediately after extubation, it favors a lot of studies favor the NCPAP as compared to the head box. It treats 6 babies to prevent 1 failure. But NIPPB in respiratory failure and prevent intubation is better than nasal CPAP. So our practice, if the baby is less than 27 weeks, we put after the extubation or after the delivery room when the baby come to the NICU in NIPPB as compared to the CPAP. This is to prevent the intubation also. NIPPV is better as compared to the CPAP, as I just told you. So these are the recommendations. After stabilization, the mechanical ventilation should be used if the baby is not improving. Duration should be minimized. Use target tidal volume ventilation as we just discussed. Keep the pH 7.3. Caffeine should be used. Short tapering course of low dose dexamethasone, as I showed you, should be considered. A recommendation is high. Inhaled budesonide can be considered if the baby is a very high risk of the BPD. Opiate should be used selective. Patient, we don't recommend routine sedation for pain. We can use the acetaminophen. The routine use of morphine or midazolam infusion in ventilated preterm infant is not recommended. Supportive care, of course, you have to maintain the temperature, the fluids, the PDA. So what are the recommendation on that? These temperature should be 36.5 and 37.5 because higher temperature or the lower temperature is stressful for the babies. We started 70 to 90 ml per kg, but most of the babies, which is less than 27 weeks, we start with 90 ml per kg per day. Fluid must be tailored individually. Of course, it depends on the sodium level, urine output, and weight loss. Parental nutrition, if you have TPN, then you should start as from the day one. The lipid also you should start from the day one. The enteral feeding as soon as possible. If the breast milk available right away, you can start it, and the recommendation is pretty much pretty good. Now, this is very important, and I put it in the bold because this is also I saw many in many units managing the blood pressure and perfusion. The recommendation is that you should treat hypotension only. I put it in the bold and the red. Recommended when it is confirmed by the evidence of poor tissue perfusion, oliguria, acidosis, and poor capillary. So, if the your pulse ox or your monitor is showing, let's say gestational age is 30 and showing the 24, 25, 26 mean blood pressure, don't start any pressure, because just check how much lactate in the blood gas, how much acidosis, how much is the capillary return is okay. बाज़ दफ़ा होता है ये कि बच्चा पूरा पिंक है, यूरिन इज 3 ml per kg per hour है, सब everything is good, but start pressure just to treat those numbers. So what happens, these pressures are not selective. They can cause the pulmonary vasoconstriction also, as I told you in the beginning of this talk, and that can cause the PPHN, and then the baby, instead of doing good, is going toward in different direction. पीडीए अगर आप समझ रहे हैं कि हीमोडायनेमिकली सिग्निफिकेंट है, पीसीओ2 इंक्रीज है, लंग्स आर वेट हैं, देन यू शुड यूज आइदर इंडोमेथासिन. आजकल इंडोमेथासिन कोई यूज नहीं करता, आइबुप्रोफेन और पैरासीटामोल. वी आर यूजिंग मेनली द एसिटामाइनोफेन. Another important thing about the hemoglobin, if the baby is cardiopulmonary compromised, then 36% hematocrit is okay. Below that, you should transfuse. If the baby requiring oxygen, we can tolerate up to 30% of hematocrit. If the baby is fine, we can tolerate up to 25% hematocrit, which is 7 gram per deciliter. So we are not transfusing the babies so oftenly. Miscellaneous consideration we already discussed about the genetics, the pulmonary hypertension, and the pulmonary hemorrhage if it happened. So these are the very simple algorithm. I took too much time. This is my second last slide. To check the airway, administer the oxygen accordingly. 30% maximum in the premature babies and 21% in the full-term babies. Examine the feature of respiratory distress. Use your Silverman score, Downey's scores. Assess the circulation. Don't jump on the numbers. होता क्या है कि when you put the UAC, you whatever you do, the heparinize and this thing, there is a micro thrombi which can give you the false low reading. क्योंकि मोस्ट ऑफ द टाइम कोई मॉनिटर पे नहीं देख रहा होता कि ट्रेसिंग कैसी आ रही है यूएसी की. UAC tracings are all over the place and they are just treating the number. So this is not good. So assess the circulation by heart rate, pulse volume, CFT, which is capillary filling time, skin color. Then place vascular access, send for arterial blood gas, stabilize the circulation. If the preterm infant, you should do all this we already discussed about. If a term infant and poor respiratory failure, shock, PPHN, it's better to mechanically ventilate. If it's not, then of course you start CPAP. If it is failed, then mechanical ventilation. So this is our daily protocol. If we anticipated preterm birth, we told our OBGYN and they already have this protocol, start antenatal steroids. Nasal CPAP, if it's more than 27 weeks of gestation and 30% oxygen, and then titrate. If the baby is not tolerating it, we intubate and give surfactant with LISA. If less than baby at 27 weeks, most of the time we give very early surfactant by LISA technique. SAT limits is 90 to 94%. Hemodynamic stability, I showed you oliguria, lactic acid, and all those stuff. Headline, we keep it for 72 hours. We in the midline because the IVH bundle we have, and we are strictly follow that. We strictly follow that golden hour, minimal handling, caffeine, cranial ultrasound we do in day number 3. We have, of course, the centers have different monitoring equipment. This is the near infrared spectroscopy. It's a very handy tool in monitor the tissue saturation, brain or gut or kidney. It gives you the saturation, but it's no I mean, you shouldn't go for it. Inshallah, when it is more in use, you will also get it. Start at TPN. We already talk about feeding. We start early as much as possible. We wait only 48 hours, maximum 72 hours for breast milk. Then we start formula. Now we are bringing the Prolacta, which is the donor milk. It is made in San Francisco, and this is the pure human milk. तो वो जो रज़ात का मसला था, क्योंकि इस reconstitute milk, we get the fatwa from the Sharia court here that it can be used because it is human milk, of course. So then we don't have to wait for 48 to 72 hours. The only thing is that is a little bit expensive. We have to remove the UVC and UAC for less than 7 days, because if you start early feeding, you will reach feeding very nicely. And still, if the baby is very sick, then we use the percutaneous catheters and minimal handling. And the baby, when is better, then we start the kangaroo mother cares. So my last slide, always keep in mind that death or disability are the most likely outcomes in those preemies. Procedures often based on physiological considerations. So your examination, your considerations are much, valuable. Of course, there are evidence, but what you are seeing, that is more important. Assumptions extrapolated from trials that have included few to no micropremies. That's the problem, that the micropremies, still there are a lot of trials which they don't have that much number of those, and they give the recommendation. So I hope I cover much of it or some of it. But time to time, we will do other things as well. And thanks a lot. I took too much time for that.